Hello, my name is Brooke Jacobs, and I took the time to dive into the impact of poor oral health on children's school attendance and performance. So basically, we looked at whether going to the dentist for routine checkups was had a negative impact on school performance, or going to the dentist for poor oral health and infection had an impact on school performance. So, to start off with the introduction, former U.S. Surgeon General C. Everett Koop during the 1980s recognized that the relationship between oral health and overall health is important. This is what started the phrase that often is repeated: you're not healthy without good oral health. And then, according to the National Institute of Health, it estimates that 20 to 30% of children and adolescents in the US have chronic health conditions. The most prevalent disease is dental caries, which is cavities, and that occurs 5 to 8 times more frequently than asthma, which is the second most common disease. Chronic illness can interfere with the child's ability to succeed in school. Missing school due to chronic illness can lead to declines in school performance, as evidence shows. More than 51 million school hours are lost annually because of illness related to dental problems, but there is no U.S. data examining the relationship between oral health and school achievement, but there are several international studies that aimed at the relationship between poor school performance and dental treatment needed. But generally, the studies showed a positive correlation between oral health status and school performance. There's more information needed to assess school absences related to oral health visits, and specifically the type of oral health concerns that contribute to absences. So we don't know if the absences are due to routine dental visits or they have an infection due to poor oral health. And so this study dives deeper into that, and there also needs to be more information uncovered in regards whether oral health status affects child's learning capabilities when they are present in school. So moving over to the methods and materials, we used data collected in 2008 from the from North Carolina Child Health Assessment, otherwise known as CHAMP, and it's used to annually collect data on a wide range of child health issues. We collected data from adults and households identified with the use of random sampling. They were asked if they have a child aged younger than 18, and if they did, they're asked to participate in CHAMP. And then if they were to agree and there was more than one child in the home, one of them would be selected through computer randomization. And then after the survey was completed, there was a 15 to 20-minute phone interview conducted. CHAMP then assessed parents' perception of their child's oral health status in relationship to their school attendance and performance. The questions that were asked included: how would you describe your child's grades in school over the past 12 months? Would you say they're mostly A's, B's, C's, D's, or F's? And then we considered C's, D's, or F's to be poor performance. Oral health status was measured with the question as well. It was: how would you rate the condition of your child's teeth? Would you say their condition is excellent, very good, good, fair, or poor? And then we used the multivariable logistic regression models to test the relationship between oral health status, school performance, and school attendance. And so if we look over at table 2, this chart puts it into perspective with numbers using the sample size of 2,120, and then you can see what the child's gender was, what type of insurance they had, their oral health status, and school performance, and all this was based off of the survey that was completed. And so moving on to the results of the respondents with the child in the household, we had 3,865 respond and agree to the survey, and then we ended up getting 2,987 with the completed interview. But then we had different respondents that were eliminated because their child was either not enrolled in school, or they had very vague responses on the survey, which was like they didn't know or they weren't sure. which ultimately led to the final sample of 2,100 children. And so most of the children were boys aged 5 to 11 years old, which was 51.6%. The results of the analysis examined the factors associated with poor school performance, revealed that gender was male, race non-white, age older, parental education level was less than high school, and all of those factors led to poor school performance. The analysis of the school absences for routine dental care and poor school performance revealed no significant relationship. However, school absences secondary to dental pain or infection was related to poor school performance. And so, of the 2,120 children in the sample, 1,656 had not missed any school days for routine dental care during the past 12 months, whereas 464 had missed one or more days, and 182 were results of dental pain or infection. And then having public assistance or no health insurance was related to absences caused by dental pain or infection, and uninsured children were more likely to miss school for dental pain than those who were. And so below the results is the pie chart that kind of puts in perspective how many days were missed due to routine care and days missed due to dental pain and infection. And so moving over to the discussion, data commonly used by policymakers and legislators frequently is outdated, as well as existing data fails to differentiate between routine visits and those associated with dental pain or infection. And so the data we compiled had details and questions that address those on oral health and school performance, which provided the information, school absences for reasons related to dental care while differentiating between absences for routine dental visits and absences of routine or absences of results of pain or infection. And so representing the entire population of the children in the state, like I said before, we were using the data from North Carolina. It was found that nearly 3.5 million school hours were missed as a result of routine dental care, and over 700,000 hours were missed as a result of dental pain or infection. That adds up to more than 4 million hours of school missed due to dental care. School absences caused by dental pain or infection were significantly related to parents' records of poor school performance, whereas school absences for routine dental care were not. Though these findings underscore the likelihood that school absence is not a standalone factor in consideration of school performance, so we did determine that missing school for infection and dental pain had a negative impact on school performance, but we know that that's not the only standalone reason for poor school performance. And so students may be experiencing pain or infection that can cause diminished educational experience because of their discomfort. And so in conclusion, the study provides updated information on school absences for dental care. It was found that children missed on average 0.5 days of school for reasons related to such care, with 17 of these absences associated with pain or infection. Although 17% of these absences in the study was associated with dental pain or infection, such absences increased the likelihood of poor school performance, whereas absences for routine dental care did not. Children in good, fair, or poor oral health were more likely to perform poorly in school, suggesting that dental disease may adversely affect children's performance independent of school absences. The findings overall suggest that improving children's oral health status may be a vehicle to enhancing their educational experience. Thank you.